are Senior Clerks Benitez, Cubello, Turnueva, and Tan, and today we are going to discuss our MCCOD case. Objectives are to discuss the causes of death in this case, identify issues that need further clarification in the case, and to reflect on the importance of correctly filling out the MCCOD for this patient. This is a case of a 55-year-old female admitted for jaundice and irritability. She is a G1B1 minority at 13 years old, menopause at 44 years old, and first child at age 32 years. She is a known diabetic for about 12 years prior to admission, known hypertensive, maintained on amlodipine 10 milligrams. She is a non-smoker and non-alcoholic drinker. Previous hospitalizations include BCMC 12 years prior to admission for dizziness and headache, and was diagnosed with hypertension and diabetes mellitus type 2. BSMMC 8 months prior to consult for breast cancer stage 3B left breast, which was noted by the patient as a 3 cm hard mass about 13 months prior to consult. Mastectomy was done on that admission. ERPR positive, HER2 new negative. Tumor size 5 cm with skin involvement and 12/15 axillary nodes positive for metastasis. Metastasis workup at the time included chest PA, which came out negative, and a whole abdomen ultrasound revealing cirrhosis. Here is the CBC on that admission. So the patient was advised for chemotherapy but refused and was instead given tamoxifen 20 milligrams once a day. She was then lost to follow-up. Patient was treated for invasive ductal carcinoma stage 3B for about 8 months prior to admission and was advised for adjuvant chemotherapy but was lost to follow-up. 6 months prior to admission, patient went back to her surgeon for dull right upper quadrant abdominal pain and was then advised to have an ultrasound of the abdomen, revealing multiple 2 liver nodules of the right lobe of her liver, about 1.5 to 2 cm in size. Chest PA was normal. No bone scan was done. 3 weeks prior to admission, her son noted abdominal distension, irritability, and forgetfulness. She was then noted to have malaise and poor appetite, thus this admission. Ultrasound of the abdomen revealed mild to moderate hematopoiesis, multiple enlarged nodules in both lobes of the liver, sizes ranging from 1.5 cm to 4 cm. Patient was managed as decompensated chronic hepatic disease but refused any treatment. Patient then succumbs 5 days after admission. Let us discuss the underlying cause of death, antecedent cause of death, and immediate cause of death in this patient. The underlying cause of death is invasive ductal carcinoma of the left breast with axillary node metastasis. This is noted by the patient as a 3 cm hard mass about 13 months prior to consult. The antecedent cause of death is secondary malignant neoplasm of the liver. So metastatic workup at the time included a chest PA, which is negative, and a whole abdomen ultrasound revealing liver cirrhosis, revealing multiple 2 liver nodules of the right lobe of the liver. And this was 13 months ago.
The immediate cause of death is chronic liver disease decompensated. 3 weeks prior to admission, her son noted abdominal distension, irritability, and forgetfulness. She was then noted to have malaise and poor appetite, thus admission, and was managed as a case of decompensated liver disease. Conditions contributing to death include the hepatitis B. The patient tested HBs antigen positive on her previous admission 8 months prior to consultation. The probable reason why the course of the patient rapidly deteriorated is that in liver cirrhosis, the patient could have bacterial translocation, which then binds to pattern recognition receptors, causing the release of pro-inflammatory molecules. This cascade of events contributes to the development of circulatory dysfunction and along with it directly favors the development of multi-organ dysfunction and failure. Ways in which the patient's deterioration could have been prevented includes early chemotherapy and completion of therapy, treatment of hepatitis B infection, frequent follow-ups for early detection of complications, and its subsequent management. Would we have managed this case differently? No, we agree that the patient should be managed as decompensated chronic hepatic failure since it is the most concerning problem. Furthermore, we don't have any issues that need clarification in the case. It is the importance of correctly filling out the MCCOD for this patient. MCCOD certification is considered the last service to our patients. It is an essential part of the doctor's duties as this is used for settlement claims, inheritance, insurance benefits, and proof of death. This document is also important for the family members since it is a requirement for burial arrangements. The information recorded in the death certificate is a foundation for a country's health policies, plans, and programs. The use of morbidity and mortality data sets priorities in health policies, identifies health inequalities, and allows appropriate resource allocation, assesses health system performance, and provides awareness of emerging health challenges. Thank you for your kind attention.